We have started the recording. Perfect. Just got it. Welcome everyone. As people continue to join us today, I wanted to thank you for being with us today for today's webinar on programming in action, nurturing care integrated into national health systems. This is part of a series that focuses on strengthening nurturing care in humanitarian responses. My name is Maria Benavides. I am the Early Childhood Development Coordinator at the Interagency Network for Education in Emergencies, or INE. And I want to thank the Global Health Cluster and the Child Health in Emergencies and Humanitarian Settings subgroup for their support and collaboration in developing this webinar series. Just before we get started, I'd like to go over a few quick housekeeping points. Participants' audio and video have been disabled, but you can still actively participate through the chat and Q&A functions. Please do submit your questions in the Q&A throughout the webinar. We will address these questions after the presentations. We have interpretation in Spanish, Arabic, and French available, so make sure that you choose the channel you desire to listen in at the bottom of your screen. And finally, this session is being recorded, and the recording and presentation slides will be shared with all registrants by email. We highly encourage you to please share the recording with your colleagues. So if we're good to go, let's get started. We have some great speakers for you today, representing a range of stakeholders working to support young children affected by crisis and humanitarian emergencies. We will hear from them on interventions where nurturing care approaches have been successfully integrated into health systems and responses, significantly shaping children's healthy development. First, we will have Sanjay Kumar Das, a public health nutritionist with experience in managing programs in humanitarian crisis and development contexts for the last 20 years. He has experience working as program implementer to develop policies and strategies, fostering inter-region collaboration and effective programming in diverse contexts of Asia, the Middle East, and Africa. Currently, he is leading nutrition program design, strategy formulation, and resource management in collaboration with multiple partners in development and emergency context of Myanmar. Welcome, Sanjay. The floor is yours.
Thank you, Media, and thank you very much to the organizer for providing opportunity to us for sharing our experience on integrating nurture and care of children and caregivers in wasting management program in the context of Myanmar. Next slide, please. This program, the experience which I am going to share is a joint contribution and work of Action Control of Fame, Handicap International, and UNICEF. So I acknowledge the contribution of ACF and Handicap International for this project. Next slide, please. So I will say brief background of Myanmar. In addition to protracted crisis in Myanmar, peoples of Myanmar are also suffering from cyclone, flood, landslide, and other outbreak of diseases, including COVID-19 pandemic. Due to intensified conflict and current cyclone Mocha, the number of IDP has spiked up to 1.9 billion, and around 63,000 people have been moved to neighboring country for their safety and security. Basic social services, including ability and access to health and nutrition service, has been interrupted due to civil disobedience movement linked with the current crisis and also COVID-19 pandemic. This has resulted in the triple burden of malnutrition, where we are suffering from high prevalence of stunting, serious public health concern for the anemia, as well as increasing trend of overweight and obesity. In this situation, UNICEF is partnering and working with diversified stakeholders to scale up multi-sectoral nutrition response to address this triple burden of malnutrition. Next slide, please. Here I will share one example of integrated nutrition center, which is a modified form of outpatient therapeutic program, which are normally used in different parts of world for the management of children with wasting. We have modified the OTP center as integrated nutrition center because in addition to treating uh, children with wasting, we have also integrated early childhood stimulation therapy for children suffering from wasting, mental health and care practices for children as well as their caregivers, and maternal and child health services, especially for common illness. That is the reason we are calling this outpatient therapeutic program as integrated nutrition center. Next slide, please. This is beneficiary flow in our integrated nutrition center. So in the first stage as an entry point, there is a management, that measurement of children with MUAC, weight and height measurement. Then next is the playing areas where our partners, volunteers provide different health and nutrition related message. And there is also play area for the children, which is linked with the stimulation of activities. Then once we found the children with severe acute malnutrition, the children sent to the appetite test, and then medical consultation is provided both for wasting and common childhood illness. After that, number fifth is mental health and care practices, where psychosocial status of mothers as well as children is assessed and necessary support is provided. Then next is early childhood stimulation therapy, where developmental assessment of children is done and necessary support is provided. And after that, on number 7, we provide the ready-to-use therapeutic food and some essential medicine. And then this is the flow of the patient in integrated nutrition center. I will mainly focus in this presentation on number 5 and number 6, which is mental health and care practice and early childhood stimulation therapy. Next slide, please. So as part of early childhood stimulation therapy, first stage is we use developmental mile assessment tool to assess the overall condition of the children, whether there is any developmental delay in the children, level of interaction between children and caregivers, and the impact of malnutrition on the developmental delays at different ages. So these 4 factors are assessed in each for each children in the integrated nutrition center. And as of our data of 2023, we have found that almost 20% of children with severe acute malnutrition are also suffering from different kinds of developmental delays. And some of them have already got disability. The chart in the right side, you can see the trend of children admitted in the integrated nutrition center, and out of that, 477 children who were assessed using the DMAT tools, around 20% children, which is equivalent to 88 children, we found with different kinds of developmental delays, and 2 children were suffering with the disabilities. This is the data for the first half of the 2023. Next slide, please. This is a diagram of intervention and flow plan in the early childhood stimulation therapy intervention. So after the developmental delay assessment, we do direct intervention for early childhood stimulation, where we have some kinds of toys and equipment which encourage the children to play and interact with other children. as well as there are some booklets which encourages the interaction between the caregivers and the children. In addition to providing direct intervention in INC, we also support and counsel the mothers to practice play with their children and self-care for children at the household levels. So there is a kind of transfer of the skills. In addition to that, if we found any children with a disability or need additional support, then we collaborate with state regional hospitals and we send them for necessary operation therapy. As well as if any children needs any assistive devices, then we link those children with ICRC to provide assistive devices. In addition to that, we have also presented some of the community-based or camp-based volunteers who conduct the home visits and create a enabling environment at the household level for the children to interact with the children of the same age group, siblings in their household, as well as other family members. In addition to that, we provide the health talk and awareness raising on the impact of malnutrition on the cognitive development of children, as well as how the children with malnutrition can be prevented from further developmental delays. And those information are shared with the other family members during at the community level. Next slide, please. This is the mental health and care practices which are linked with both psychosocial assessment of caregivers, mothers, as well as children. And for this one, we use 4 booklets to assess the level of interaction between caregivers and the children. And based on that assessment, we categorize the both caregivers and children and do some intervention. Like if we found mothers with a high level of stress, we try to explore the reasons for that. And then we reach out to their family members like their husband or the mother-in-law and provide community level counseling to the family members to support the caregivers for their proper psychosocial support and so that the mothers can take care of their children. At the same time, to promote the interaction between the children and mothers, even in the health facilities or integrated nutrition center, we have toys and equipment for engaging children and mothers at the INC level. Next slide, please. So based on this program, our lesson learned is this disability, developmental milestone assessment tools has been now simplified and can be used even by the community volunteers. And this has encouraged a scale up of this program at the community level, and basic developmental delay are addressed at the community level, which ultimately decrease the overcrowd in the integrated nutrition center. At the same time, another lesson learned is as we are collaborating with different stakeholders like ICRC for assistive devices, general hospital at the state level, it has resulted in a strong coordination and collective understanding among partners to ensure comprehensive service delivery in adherence to the standards. And integration with the social protection, SBCC, give more visibility, access and coverage of nutrition program. Definitely, we also have some challenges considering the context of Myanmar. One is the inadequate funding for expansion of this INC program in the other nutrition centers, and travel authorization due to current crisis has created a kind of barriers for home visits and follow-up of the children at the community level. Security and several checkpoints also have affected regular flow visits of the children to the INC, which is a requirement for the treatment of children with wasting. Next slide, please. So our major recommendation is currently we have started this INC in a very small geographical area in the Rakhine state only. But for the long term, our plan is to expand this early childhood stimulation therapy and maternal health and care mental health and care practices with other nutrition centers. And for that one, we seek financial support for a scalable program as well as to enhance the capacity of the nutrition staffs working in the nutrition center to integrate early childhood stimulation therapy and mental health and care practice services in the existing nutrition program. Thank you and over.
Thank you, Sanjay, for sharing the Integrated Nutrition Center's experience. It really showcases how this type of integral interventions can serve as entry points for nurturing care approaches that effectively addresses children's holistic needs. Before we move on to our next speaker, just a technical adjustment. Aisha, Dr. Dalal has a preference to share her own screen for the presentation. So if we can allow for that. Thank you so much. Perfect.
So it is okay for you?
Yes, if you can put it on presentation mode, that will help us to see better the slides. And as we work on that, I will introduce Dr. Dalat Al-Muhi, the program coordinator with Aga Khan Health Services in Syria. Dr. Dalal is responsible for managing, coordinating, and overseeing all of the Aga Khan Health Services community health programs from inception to execution, ensuring that objectives are carried out on time. From 1990 to 2006, Dr. Dalat worked at her own clinic as a practice dentist, and in addition, worked as head of the oral health department and quality improvement officer at the government health district at Salamiyeh City in Hama province in Syria. Dr. Dalat, please go ahead.
Thank you. Thank you very much for your introduction. At this time, I will present the experience of Syria as EKF and Aga Khan Health Services as a part of EKDN agency have worked to improve ECD program in Syria, even before the crisis or after the crisis. So what is the situation before the crisis? The crisis started in 2011. Before the crisis, there was a good experience regarding to ECD program. EKF, the health program, ECD program in EKF was working to improve the concept of ECD, and there was many attempts to integrate this concept to the kindergarten program, develop a teacher program with ECD, and also there was a good intervention and relationship with Ministry of Health and Ministry of Education to improve the national strategy regarding to ECD. Also, there was a good relation with UNICEF in Syria to lesson learned and exchange lesson learned regarding to ECD approach. But the crisis starting during 2011, the situation became very bad. So the EKF couldn't follow up and continue with this intervention. So the intervention was based on the community intervention through many kinds of program similar to My Child and I Am Ready to Go to School, open days with the children and their parents or caregiver. All this intervention was aimed to learn the parent how they can motivate their children, how they can learn the children to coping with the bad situation. This is during the crisis. What is about the health system in Syria? The health system in Syria has a good opportunity. The health system has a week that no program reached to the children during the first 1,000 days. Also, the crisis impact on the health situation and the ECD, there is a very high displacement rate in all the governorate in Syria. So what is the better situation? It was the best intervention to integrate ECD and to the health intervention, to the health system. Also, we can consider that the health system still is good in Syria, so it is become a good opportunity to consider is as a entry point for the ECD in the health system. What is our strengths and weakness in the health system in general and ECD integration in Syria? In Syria, still the immunization program is very good and have a good reach to the target group, the children under 5 years. The experience of the IMCI is good, and already this IMCI have 13 visits for the health center. Already we have MNCRH services. It is integrated in the health center, primary health center. There is a good number of health worker, trained health worker, and also we have a home visit to the in all targeted in Syria. But
Dr. Dalat, excuse me the interruption, but if you can show the slides in presentation mode, so it can show in your full screen and people are able to see it. Right now, it's really hard to read the slides as you're showing.
It is not clear. It is not clear.
Right, in the bottom of your screen, there's a button so you can click and it shows in presentation mode, and that's helpful for zooming in and being able to see the slides clearly. And
it is share, yes?
Yes, we are seeing your screen, but we're not seeing it in presentation mode, the PowerPoint presentation. So we're not going from slides to slide, and we're not also be able to see because the text is very small.
It is not. It is right. Okay, or no? If it is not, you can share your screen. I will stop.
Thank you so much. Maybe we can go back to Aisha sharing your screen if that's okay. And I apologize for the inconvenience.
No, don't worry. Okay.
Thank you, Dr. Dalal.
Welcome.
Aisha, if you don't mind sharing your screen again, thank you so much.
Okay.
Perfect.
So I will continue. Thank you, Maya. The weakness at this program, it was that the organization didn't consider this opportunity to motivate or apply the ECD program in the health center. Also, there is a many program regarding to child growth monitoring and IMCI, nutrition, but all these programs didn't consider the child as one person. It is partial implementation. Also, the vertical program, no coordination between the ECD, the child care, the MNCR, each program works separately. Also, there is a good number of health workers, but they are not ensured that every child have to receive all the comprehensive child services. The another point, the home visit program in the health center didn't take in their consideration that they have to reach or educate the parent about the child growth monitoring. Next, please. What we have done during the period from 2016 to at this till now. Next. We coordinate with Ministry of Health and other organizations similar to UNICEF, WHO, to piloting this project, especially in Salamiyah district from Hama Governorate. So we coordinate with the Ministry of Health to select 8 health centers as a piloting, assess this the situation, the number of health workers, the medical equipment, the knowledge and the practice of the health worker. Then we have advocacy meeting with the decision maker and the national level of Ministry of Health. develop a training program depending on scientific and the trust resource of this material, similar to CDC or WHO or American Pediatric. Establish and develop TOT, review the material and approve the training from the CEDC and the Lancet and the American Pediatric. Orientation session at the governorate, the target governorate or province, which will apply the target data. Capacity building for the health worker who will apply this project. Okay, next. Capacity building. Assess the result in Salamia. After we apply this, we assess the result in Salamia as a piloting, present and share the result with Ministry of Health and other concerned partner, expand the, and we get the approval from the Ministry of Health to expand the implementation to 6 governorate in Syria, and including 68 primary healthcare center. EKHS has the responsibility to support the implementation in this and those BHC and support them with the required material similar to stationery, to some ECD material, some medical equipment, right, weight scale or length scale, just this, and develop referral system for the cases which we have assigned in the health center to have follow up and check their situation. Next. At this training and this link with the Ministry of Health, there was the definition with the ECD, introduction to ECD, and this brainstorming and CECD, it was considered that the key message of ECD can we provided in the health center with the parent directly, build on the existing intervention and services and the program. It is we have in the Ministry of Health. The integrated counseling and motivation and form, it was depend on CDC. They already have 13 visits depend on the age of the children, starting from 0 to 5 years. We can see in the link the form and the application. The next, please. This is a sample of the 13 application from CDC. The next, it is depend on the age. Depend on this guideline and resource from CDC and Lancet, we develop this tool to develop and to check the simulation for the children and to provide the health center with the tools which they can need for to provide the counseling to the parent. Organize the services in each health center according to the individual health center. Promote the community to be part of these services. Then we improve the follow-up and supervision system in the health center. The next, please. This is the criteria of the child-friendly health center. There already we have 10 criteria to consider this health center as a friendly space for that child. I will not present all of them, but we can consider that all of the health workers have to be aware about the concept of ECD. The flow of the child inside the health center have to be designed to ensure that every child have to receive the package of required health services regarding to immunization, growth monitoring, development, nutrition, all this. All the community have to be part of these services and contribute to raise awareness about this ECD. So we can move to the next, please. We can also move either. This is the criteria of child-friendly health center. Then the other. What we have to encourage the health worker to adopt this program. It is not new, but it needs some adopting from the health worker. So we try to improve the training program to be very interactive, depend on role play, depend on real example. So the health worker was very exciting in the training, and most of them expressed that this training is very interactive. Most of them they expressed that this training feel that this project is touched them. It is they hope they have received this training before they grow their children. Next, please. After that training for the health worker, the health worker was facilitate community health awareness to raise awareness the parent about the ECD, how they can motivate their children, how they can do many play game with their, depend on the local resource from their home, not to have to buy expensive tool or material. Also, the community health volunteer was very interactive during this program to participate and raise awareness for community. The next, please. It was very important to reorganize the place to be suitable and interactive for the children and health worker to be comfortable, to have session with the children themselves and with the children and parents to work together and play together. Okay. After this, we have assessment for the program after 3 or 4 years. So we met around 57 person from the supervision, the health worker themselves. So the result was very good and positive and encouraged us to expand this project. So 100% of the people with we interviewed that expressed that this program improved their knowledge, practice, and adapting for the this program. The next also, most of them mentioned that there is a good or success story regarding to their practice or for the with the children. This was have to be bespoke. Okay, don't worry. Can we please next please? 75 of the children under 5 visit of the health center received the comprehensive child care services. As I mentioned, immunization, growth monitoring, development, IMCI, all these. 80% of caregivers who visit the BHC received counseling about ECD. Many types of late development have been assessed and referred to the suitable places. The next. This is the reference which we have bent on to develop the training program. It is similar to ECD, CDC, the Lancet, American Pediatric, like this. And thank you for your listening.
Thank you, Dr. Dalal. I think from your thank you. I think from your presentation, it is important that we acknowledge that there are important challenges and gaps in supporting young children that are affected by humanitarian crisis, especially when it comes to the low coverage of ECD interventions during the first 1,000 days of life and prioritizing what interventions to undertake. But we can find ways to overcome those gaps and challenges by building on existing services and interventions. So thank you for that.
Thank you very much.
Before we move on into our next presentation, I would like to ask our English-speaking audience to go to the English channel of interpretation instead of staying in the main audio channel. And with that, I would like to give the floor to Cesar Eduardo Luna Vivas, who is the Early Childhood Development Consultant for UNICEF Colombia. He has a bachelor in education with an emphasis in special education. Eduardo is a specialist in childhood and youth. He has 15 years of experience as an early childhood teacher and a consultant in early childhood, early education, disability, migration, and care for children in conflict contexts. Please, Eduardo, come in.
Buenos días para todos y para todas. Un gusto estar en este espacio compartiendo la experiencia de la respuesta en contextos de emergencia por causa de la migración en nuestro país, en Colombia. Sean todos bienvenidos y bienvenidas. Siguiente diapositiva, por favor. Ok.
Next slide, please.
Ok, muchas gracias. Como ustedes seguramente habrán escuchado, nuestro país ha venido experimentando en los últimos años un significativo aumento del número de personas provenientes de Venezuela que, digamos que en la necesidad de poder ubicarse en diferentes lugares de la geografía colombiana, han llegado a asentamientos humanos informales, pero por otro lado, un número importante de personas, niños y niñas especialmente, han continuado transitando por las rutas terrestres de acceso a nuestro país con conexión a otras naciones de Centro, Sur y Norteamérica. Sabemos que en muchas de esas rutas de tránsito no son seguras, son rutas no aprobadas por las autoridades migratorias colombianas. Esta situación de emergencia por causa de la migración en el año 2020 encontró en suma con la pandemia de COVID-19 un escenario propicio para aumentar las desigualdades, los casos de tratas de personas, las violencias basadas en género y ambientes tóxicos y de alta carga de estrés para los niños y para las niñas migrantes. Sobre esto último, sobre este significativo aumento de niños y niñas, Naciones Unidas, UNICEF Colombia decide diseñar una estrategia que se denomina PIO, que es un poco una sigla que permite acercarnos a lo que entendemos como un espacio protector, un espacio lleno de posibilidades de participación de los niños y las niñas en clave de promoción del desarrollo infantil y aprendizaje temprano, pero especialmente enfocada en acciones de protección, WASH, género, salud y nutrición, educación y rendición de cuentas. Y en ese sentido, pues hoy tengo la oportunidad y el privilegio de contarles a través de muchas imágenes cómo se desarrolló el proyecto PIO y cómo se viene desarrollando, porque podemos decir con mucho orgullo que UNICEF a través de esta estrategia ha logrado posicionarse en territorios fronterizos y en territorios de paso de conexión a otras naciones, convirtiéndose en una respuesta efectiva, pertinente y sobre todo con un enfoque de promoción del desarrollo infantil y cuidado cariñoso y sensible. Estas imágenes dan cuenta un poco de parte del alma de la estrategia PIO, que son los encuentros con niños y niñas. UNICEF, a través de los socios implementadores de este proyecto, porque han sido varios en varios departamentos de Colombia, han encontrado la oportunidad de tomar distancia un poco de la mirada asistencialista de la respuesta humanitaria y por eso hablamos de que preferimos no atender niños, sino encontrarnos con los niños y las familias y compartir con los niños y las niñas. Y aquí cobra muchísimo sentido no solamente las acciones relacionadas con la promoción adecuada de la salud y la nutrición, sino que especialmente tomamos elementos de la política de primera infancia de nuestro país, sobre la cual los niños y las niñas deben vivenciar de manera natural el juego, las expresiones artísticas, las expresiones literarias y la exploración. Y con esas ideas, con estas vivencias naturales que llamamos nosotros actividades rectoras, pudimos organizar toda la parte programática, pedagógica y operativa del proyecto. Adelante, por favor, con la siguiente diapositiva. Continuamos, por favor, con el siguiente slide, con la siguiente diapositiva. En este momento, Colombia tiene la operación del proyecto PIO. Inicialmente lo tenía en los departamentos de la parte superior derecha, Santander, norte de Santander y Arauca, pues porque efectivamente son los departamentos, parte de los departamentos fronterizos con el hermano país de Venezuela. Sin embargo, como se pueden dar cuenta, hemos extendido el radio de acción del proyecto a departamentos de obligatorio paso de otras rutas migratorias, el departamento de La Guajira, en el extremo norte del país, que sigue siendo departamento fronterizo con Venezuela, pero encontramos ahora departamentos que tienen una fuerte presencia de rutas para acceder a países del sur, en este caso el departamento de Nariño con conexión a Perú y Ecuador, y el departamento del Chocó que tiene pues conexión con el Darién y pues con la situación conocida de migración a través del tapón del Darién con conexión a Panamá. Siguiente diapositiva, por favor. Rápidamente, entonces, les voy contando un poco cómo está organizada la propuesta. Hablamos de un vehículo que se llama Chiqui Van. Esta es la excusa. En Colombia, Chiqui está asociado a algo que es poderoso, que es pequeño, que es querido, que es cariñoso. Y en ese sentido, este vehículo se mueve por las rutas migratorias, por donde encontramos a la población migrante con vocación de tránsito. Y decidimos entonces que este vehículo pudiera parar en diferentes rutas, en diferentes lugares de las rutas migratorias. Por eso hablamos de un servicio o de una forma de atención itinerante, donde este vehículo despliega una propuesta de orden pedagógico en donde se hace obviamente una orientación muy importante en términos de salud, WASH, salud bucal. Sabemos nosotros la importancia de que las poblaciones migrantes puedan acceder a agua potable y a insumos humanitarios. Sin embargo, también vimos la necesidad de que este vehículo, esta Chiquiván, llegara con experiencias a los asentamientos humanos informales. Seguidamente, en la forma de atención fija que denominamos nosotros, llegamos a espacios aprobados por los grupos interagenciales de flujos migratorios, lugares seguros, lugares con una respuesta muy variada de servicios, con la presencia de otros organismos internacionales y también de la institucionalidad colombiana. Todos se caracterizan por estar liderados por profesionales de diferentes disciplinas, pedagogos, profesionales del área de la salud y profesionales del área psicosocial, para poder dar una orientación integral en términos de promoción del desarrollo, apoyo y orientación psicosocial, activación de rutas en casos de vulneración de derechos y, por supuesto, en el caso de la promoción de lactancia materna y alimentación complementaria, el apoyo de profesionales del área de la salud. En el caso de la forma de atención itinerante, descubrimos una manera de poder llegar a los ámbitos hospitalarios usando la misma metáfora del nombre de la estrategia, que es PIO, y llegamos a través de una estrategia que se llama PIO Te Busca, y es poder acompañar a las lactantes y a las gestantes en los primeros días en entornos hospitalarios y ofrecer orientaciones que favorecieran el cuidado cariñoso de esos primeros días con sus bebés. Siguiente diapositiva, por favor. Aquí el juego cobra un sentido muy importante y la literatura. Cada espacio tenía una colección de literatura especializada para la primera infancia que buscaba promover interacciones intencionadas y sensibles entre adultos, cuidadores, niños y niñas. Adelante, por favor.
Next slide.
Please, next slide. Ok, bueno, creo que podemos avanzar en esta, por favor. Siguiente diapositiva. Esta era una explicación de dónde estamos con nuestro vehículo.
Next slide.
Thank you. Quiero ir cerrando nuestra intervención con las estrategias transversales, y es decir, la gente se preguntará qué pasaba en esos espacios protectores ricamente ambientados desde una perspectiva local, desde una perspectiva que invitara al disfrute del juego, del arte y de las expresiones artísticas. No eran charlas, no eran clases, eran vivencias naturales en las que el talento humano diseñaba diferentes posibilidades de participación de los niños y las niñas. Tenemos una estrategia llamada Mi Amigo el Pana. En el caso de Mi Amigo el Pana Descubre, los niños tenían la posibilidad de interactuar con una serie de materiales que no necesariamente eran juguetes sofisticados, sino que eran materiales naturales, materiales didácticos, materiales que no necesariamente están pensados como juego, que llamamos en Colombia y en general en la literatura, materiales no convencionales, y otros materiales que hacen parte como de lo que conocemos como los materiales que se usan mucho en experiencias pedagógicas, plastilinas, colores y diferentes tipos de papel. Los niños jugaban con el material, no sabían que ese material que iba en esa mochila era para ellos, primero interactuaban con el material, enviábamos mensajes claves alrededor de la protección, de la salud bucal, de la necesidad de consumir agua potable, de pernoctar o dormir en lugares seguros, libres de vectores, libres de roedores u otros animales que afectaran la salud, y al final se quedaban con este material, con esta mochila llamada Mi Amigo el Pana. Teníamos Mi Amigo el Pana muñeco, que nos funcionó muy bien como estrategia en los asentamientos humanos, porque nos permitió entregar un kit sobre el cual se desarrollaba una experiencia de 4 encuentros que promovía el fortalecimiento de capacidades parentales, el cuidado cariñoso y sensible, la resiliencia, y el material permitía elaborar un muñeco que era Mi Amigo el Pana, pana asociado a una palabra muy fuerte en la cultura venezolana que quiere decir amigo o amiga. Y los 4 encuentros permitían identificar potencialidades en las familias alrededor del cuidado cariñoso y sensible. Podemos avanzar. Pío te busca, ya les mencioné, en lugares en donde no podíamos llegar con la chiquiván, no era un lugar, digamos que, en donde hubiera mucha presencia de otras agencias. Estamos hablando de hospitales, terminales de buses, terminales de espera en los que las poblaciones hacían conexión con otros medios de transporte. Siguiente slide, next slide, please.
Next slide.
Please, next slide. Ok, otra estrategia que nos funcionó muy bien en asentamientos humanos y en algunos lugares donde podíamos tener más de un número de encuentros con la misma familia, se llama la manta que abraza. A través del arte de tejer y de coser, retomamos la posibilidad de que las familias recordaran lo mejor que les había pasado en su tierra, en sus países de orígenes antes de llegar a Colombia, y este objeto cariñoso sobre el cual se construían relatos y recuerdos era una manta que quedaba para los niños y para las familias. Y en el caso de Mi Amigo el Panatelé, la colección de literatura tenía como propósito escoger cuentos en los que promoviéramos el cuidado cariñoso y también, obviamente, la promoción de la salud, las relaciones en ambientes adecuados, las relaciones que se tejen entre padres e hijos, y fue sin duda alguna y sigue siendo una de las potencias de esta estrategia, y es la literatura como posibilidad de conexión entre países y entre culturas. Next slide, please. Siguiente slide, por favor. En los espacios fijos teníamos un espacio, no, anterior, please. Para ir ya hacer, ok, gracias. En el caso de los espacios donde teníamos la posibilidad de tener un lugar fijo, se diseñó un ambiente diferenciado y especial para las mujeres gestantes y lactantes. Decidimos también tomar distancia de las charlas complicadas, de las charlas largas, de las charlas técnicas sobre consejería de lactancia materna y alimentación complementaria, y en ese sentido diseñamos ambientes, recursos pedagógicos y metodologías que permitían conectarnos a través del juego, la exploración y de la literatura. Y con ello creamos una batería de metodologías que se implementaban en los diferentes espacios, en el que acompañábamos a las gestantes y lactantes, bien aquellas que venían en tránsito hacia otros países o bien hacia aquellas con las cuales podíamos también promover otro tipo de experiencias, otro tipo de rutas sobre el cuidado del recién nacido, la alimentación en los primeros 1000 días, los controles prenatales y la valoración del desarrollo. Adelante. Next slide, please. Ya para ir terminando, las grandes lecciones que nos quedan de Pío. Pío sigue en este momento operando en diferentes departamentos del país. Arrancamos con 3 y ya vamos en cerca de 7 departamentos, 6 departamentos. Siguiente slide, please. Estamos haciendo presencia en Necoclí, que es un contexto distinto, donde hablamos de niños y niñas en condición de playa y cuyas familias obviamente quedan varadas en municipios costeros en búsqueda de mejores alternativas para continuar su tránsito a través del tapón del Darién, o definitivamente desistir de esto y regresarse a su país o quedarse en municipios y comunidades de acogida, donde busquen mejores oportunidades para sus niños y para sus niñas. Hicimos transferencia de lo metodológico y lo programático con otras agencias, con otros operadores. Hemos inspirado también a muchas familias para acoger las propuestas pedagógicas y de orientación en salud en sus entornos comunitarios y en sus entornos familiares. Y para este año y el siguiente estamos proyectando llegar sobre todo a servicios de educación inicial, es decir, a jardines infantiles y a espacios, en este caso, hospitalarios. Gracias.
Thank you so much, Cesar Eduardo. Colombia's case shows resourceful ways and contextualized ways to reach and support children on the move or in transit that are often overseen in other service provision. So thank you for highlighting that case. Now we will hear from Nasibu Agonafir, Senior Team Lead at PATH Ethiopia. He has more than 16 years of progressive professional experience in program and project management, capacity building, system strengthening, and monitoring and evaluation in areas of early childhood development, public health, nutrition, and WASH. Prior to joining PATH, he worked with various non-governmental and governmental organizations, including Save the Children, CARE, and the Ethiopian Ministry of Health. He possesses a master's degree in public health and business administration from the Jimma University, and currently pursuing his PhD in community nutrition in Addis Ababa University. Please go ahead.
Hello all. Thank you for your time and for listening to me. I would also like to thank the organizers for giving me this opportunity. I'm working in Ethiopia in PAS as a team leader for early child development program. And now I'm presenting the experience we have here in Ethiopia in implementing integrated ECD and maternal mental health in primary health care in post-conflict or emergency in northern Ethiopia. So the title of my presentation is Promoting Early Child Development, or Promoting Early Child Development and Maternal Mental Health in post-conflict or emergency context in Ethiopia. Next slide, please. PAS is, as PAS we are working globally with 1,500 plus staff in 70 countries, and 58% of our team based outside of the United States, and 93% out of our team members are from countries where we work. Our mission is to advance health equity through innovation and partnership. Next slide, please. So, the armed conflict in northern Ethiopia caused tremendous loss of life, displaced millions of people, and distracted infrastructures, including health facilities across the war-affected regions. Rapid assessment demonstrated lack of basic services, severe food insecurity, and exposure of children and caregivers to stress and violence. These experiences are likely to negatively affect young children's development. To respond to the need, PAS has built on its earlier work with Federal Ministry of Health to integrate developmental monitoring, counseling, and PlayStation in key maternal newborn child health nutrition services, and has, with FMOH approval, added maternal mental health component to this intervention, drawing on this experience in the region. We also supported a big ECD initiative in Addis Ababa, which is multi-sectoral, which also a component of integrating this intervention, the ECD interventions into the primary health care. And currently it reached all the public health centers in the city, which are 101. More than 3,000 staffs in these service providers in these facilities have been trained and currently engaged in providing developmental monitoring, counseling, and nurturing care, and promoting facilitating PlayStation to promote responsive caregiving, play, and other nurturing care component as well. Next slide, please. So this is the project area for the emergency one. It is a northern part of Ethiopian Amhara region in 6 districts. The target, the direct beneficiaries were more than 60,000 and 5 children and about 15,000 pregnant and lactating women. It was implemented between January 1st and March 2023 and supported by BP Philanthropy. Next slide, please. So the key, or one of the key intervention is integration of developmental milestone monitoring and counseling in routine MNSHN services. So 421 service providers, including health extension workers, were trained on integrating its intervention in ANC, PNC, well-baby clinic, and under 5 services, and received FMOH approved job aids and mentorship through the project support. As a result, 99 primary health care facilities, which include 18 health centers and 81 health posters, provided developmental monitoring and counseling service. Service delivery report between June and February 2023 indicated that more than 100,000 children under 5 years of age were monitored for the developmental status across the 6 project woredas. Of these, more than 1% were identified with suspected developmental delays, and 98 were identified with confirmed developmental delay and referred for the other required services. The assessment we conducted provided some qualitative and quantitative information. And the children, one of the providers said, the children now are not afraid of the provider during EPI and sick baby clinic. When you compare it before ECD was implemented, this is how the health provider expressed the effect or the outcome of the ECD service. This picture shows the tools, the job aids. The green one is the milestone monitoring poster, which is as age appropriate or age appropriate milestone for helping the service provider to classify as delay, no delay, and suspected for development. And the other one is the yellow one is the counseling poster that the provider uses it to provide counseling on key recommendations on play and communication activities, which is also age appropriate for the children. Next slide, please. The other intervention is promotion of play session in waiting areas and pediatric ward. These play sessions are run by health providers at health facility waiting area, pediatric wards, and stabilization centers. Children participate with their caregivers and or other children as a group using homemade play materials in prepared play box. So what you see on the picture is a caregiver playing with some locally or homemade book for the child and playing with the child. And the other picture shows the recommended play material for the play books, for the play box or the play kit that are recommended, that are being used in health facilities, which are homemade and things prepared from locally available and used materials. And we are not promoting or we are not using the store-bought, just to ensure affordability by the larger community, as well as also which we also believe it encourage or it program the children in a kind of creativity while they develop while they see this develop with local materials and developed by their parents, and it would also create opportunity for the parents to interact with the children with more time while preparing these materials at home with the children. One provider said, previously we used store-bought toys at the stabilization center, but now we use homemade play materials that are made from easily available and used materials. This helped us to produce the type, color, and quantity of play items that we want at any time. It also makes it easy to us in encouraging caregivers to prepare them at home for their children. This is how they put it in their language. Next slide, please. The other intervention, third one, is maternal mental health screening and counseling in ANC and antenatal care and postnatal care touch point. 363 service providers, including health extension workers, were trained on maternal mental health intervention and received job aids and mentorship through the project support across conflict affected 6 waradas. As a result, 99 primary care facilities began providing integrated MMA service for the first time. Service delivery report between June 2022 and February 2023 indicated that out of close to 17,000 women who sought routine ANC and PNC service in 6 waradas, 97% received integrated screening and counseling for maternal depression. Of these, 218 were identified with mild maternal depression supported and linked to the mother sexual support group for peer support. 7 women that had moderate or severe depression were referred to the nearest referral hospital. Also, a key informant said, when I assess the depression status of the mother in our health center, I talk to them. They get relief from stress when they share the experience and they feel healthy. So now most of the suspected cases of depression return to normal. And the other one also said, I have been worried about mothers whom developed depression. There was nothing I could do for these mothers. The training solved my worries and taught me how to provide possible solution to mothers with mental health problem or depression problem. Next slide, please. And the other intervention is community-based psychosocial and parenting support. This is a community-based model where we established a community group, a mother-baby support group, to support each other on matters of psychosocial support. And as I said earlier, those mothers who are identified with depression symptoms also linked to this support group to help each other or to get support from the peers or the community. 117 trained health extension workers were trained to establish mother group and facilitate 14 sessions on topics such as maternal mental health, co-parenting, child nutrition, and development. As a result, 55 mother-baby psychosocial support groups were established and enrolled or served more than 800 mothers across 6 project waradas. Most groups met every 2 weeks in their nearest health post. 70% of women completed all 14 sessions, and 86 completed between 11 and 13 sessions. The pre and post intervention evaluation indicated that while 44% of women showed mild depressive symptoms at the start of the program, only 4% reported such symptom in the end. 4% of women had moderate or severe depression at baseline, but no women were identified with such symptom at program closure. Caregivers' knowledge score in child development and nutrition increased from 31% at baseline to 61 at end line. A mother support group help us. This is what expressed by a key informant, help us to share our experience and reflect on the things we faced. We talk about hot issues as well as stressful condition, and it gives us relief and help get rid of painful things from our mind. It also offers opportunity to stimulate children and makes them active with when they are playing with locally available materials. Next slide, please. So with regard to scalability and sustainability, these are what also explained by the key informants. One said, staffs are trained, the job aids are available, HMIS registers and DHIs to have incorporated ECD, that's to mean the indicator, and DHS reporting includes ECD components, so this is a good opportunity to sustain the program. The other one said the health center management integrated this intervention with our supervision checklist for the health center and health posters to monitor the implementation. The other one said maternal mental health is one of the services needed for pregnant and breastfeeding, and it's our responsibility to provide comprehensive ANC and PNC service. This is how they understand the interventions and how they feel it is scalable and can be sustained very well. The other also said we will sustain the program because this is one of the Ministry of Health's activity. So as a lesson, what we learned from this is one is integration of ECD and MMH into the PHC in post-conflict or emergency is a highly promising approach to help the caregivers of children to recover and to reach the potential in life for the children. As a recommendation, the key recommendation we have is the extensive impact of the conflict and drought in Ethiopia or other places required at-scale implementation of similar projects to improve access and quality of integrated maternal, newborn, child nutrition and ECD, as well as MMH service. There is a need to advocate for inclusion of ECD and MMH service in emergency and post-conflict response at health facility and community levels. There is also a need to advocate for maternal intervention in antenatal and postnatal service to be integrated nationally in both the emergency and the development context. Let me stop here. Thank you very much for your time again.
Thank you so much, Nasiru. I would like to highlight the important role that mental health has in children's healthy development, especially during and after an emergency, including the caregivers' mental health as it impacts their ability to provide responsive caregiving. We would like to now show a video of UNICEF's work in Afghanistan and how they have managed to enhance health and nutrition services with ECD interventions or early childhood development interventions over the last year.
The earliest years of life shape a child's future. Together, good food, active play, security, and responsive caregiving can build a child's brain, paving the way for a lifetime of good health, learning, and opportunity. But more than 40 years of insecurity, crisis, and poverty have deprived millions of children in Afghanistan of this critical window of growth and development. Amidst the ongoing humanitarian emergency, and despite not having an early childhood development program, UNICEF has scaled up ECD activities for millions of children. We've established 1,400 child-friendly spaces where children can play safely. 50 urban daycare centers where pregnant and lactating women get nutrition counseling and malnourished children get treatment. Between January and June, they screened 600,000 children and reached 29,000 caregivers with nutrition counseling, including cooking demonstrations. We've supported parents with positive parenting messages nationwide, including in hospitals. In 2023, we've given vitamins to over 870,000 girls and boys and vaccinated over 8 million against preventable diseases. Our mobile health and nutrition teams, which include psychosocial counseling for vulnerable mothers, reach rural communities, and much more is planned. From placing 650 social mobilizers in communities and supporting mothers in family health households, to increasing child support programs, early child education programs, and social services nationally for building strong foundations for our youngest citizens in an ever-changing environment. So, whoever he is, wherever she is, we give every child the best start in life.
We have Melanie Galvin here with us to share a few extra remarks. Melanie is Chief of Nutrition of in Afghanistan. She has worked as chief in Somalia and Pakistan for UNICEF. She has more than 25 years of experience in overseeing both health and nutrition projects. Melanie, please go ahead.
Thank you. Good afternoon and good evening, everybody. I think the context in Afghanistan was quite different from everyone else's presentation. And in a way, it was quite unique. We did not have an ECD program prior to the Taliban taking over. We did not have an ECD strategy in the country. UNICEF, after the Taliban took over, UNICEF started to run the health system. All of the money for the health system flows now through UNICEF, and that hasn't changed. We had a huge opportunity, though, in these very difficult circumstances, in that we had very high levels of funding that came into the country, which allowed us to scale up many of these building blocks of ECD, even in the absence of a comprehensive strategy. And so we're a country that is operating at a national scale on a number of these parameters. We still have some work to do. We would like to develop an ECD network of like-minded partners. We don't have an inroad into the government that would be functional for us. So a network of external partners is the way to go with an interim ECD strategy. We don't even really have a mapping yet of what other people do. We know what we do, and that's it. So it's a very evolving context here. And I think in general, when I see other presentations in these really complex programs, we're still years away from that. Nevertheless, we still will maintain a very high scale of activities probably for the next couple of years, which will benefit millions and millions of children in Afghanistan. So that's it for me. Thanks.
Thank you so much, Melanie. And I would like to thank you and all of our wonderful speakers for today. We still have a few extra minutes for Q&A. So will each of the presenters mind coming back on camera if that works for you? And for the Q&A, we will have the support of Aisha Kadir, a pediatrician and senior humanitarian health advisor for Save the Children International. She works in clinical care, public health research, health policy, and advocacy. Her clinical work is in pediatrician emergency medicine and social pediatrics in Europe and humanitarian settings. Thank you, Aisha, for coming in.
Thank you so much, and thank you to all the presenters. I think just a thought after having watched these 4 presentations in the video and listening to Melanie's comments. I think it's really I think what's really striking is that it's very clear in many different ways, and really in any health and nutrition interventions, it shows that it's entirely feasible to very effectively integrate nurturing care approaches to promote early child development. And there's some really striking outcomes. I think in the presentation from Ethiopia, the fact that children were not afraid. Health workers will very often recognize when a child is unwell and they are crying and they are difficult to get them to cooperate with an exam, and you want to listen to their heart and their lungs to see, do they have a pneumonia? Do they have, doing a clinical exam on a child can be very difficult, especially when they're frightened. So if this actually helps to improve the ability of diagnosis and care, then that will also improve health outcomes. So it's really, I think, quite profound and impressive. Also, the maternal depression sort of improvements and knowledge about development. So I think actually just leading into one question that seems to come up in many different ways from a number of people is relating to what kinds of tools are used to basically screen for child development, and there are a lot of tools out there. So I think maybe we can start with, sorry, I'm just double checking who, there were some that were specifically for Sanjay, but also Dr. Dalal and Eduardo, everyone really. So can, if the speakers could just talk a little bit about which tools were used to screen for development and how did that go? How was that decision made and how did that go? Over to you, Sanjay, first.
Yeah, so I mean, in the Myanmar, we are using 3 kinds of tools. The one DMAT tools, that is the developmental milestone assessment tool, we call this, which is normally used for assessing the impact of malnutrition on the development of children. And mainly we assess this in 4 categories, like one, sensory development, then neuromotor development, social skills, and communication or language related skills. So these 4 broad topics are covered on that. So this is done at the Integrated Nutrition Center by trained nurse or nutritionist. Now, during the COVID pandemic and considering the inaccessibility of Integrated Nutrition Center, we simplified that tools as community-based DMAT tools, and that can be used at the community level by community volunteers. So that is community-based DMAT tools to assess the developmental delay of the children. Then the third category is mental health and psychosocial status of caregivers, because as there is a protracted crisis ongoing in Rakhine state of Myanmar for a long time, so caregivers are also psychologically affected, depressed, and sometimes we found that they are not fully capable to take care of their children. So it is very important to assess the psychosocial status of caregivers, mothers, and based on that, we have developed another tools to assess the psychosocial status of caregivers. And for that one, we have 4 kinds of booklets, which normally used to assess the level of interaction between caregivers and the children. So in that way, we have the 3 tools used at different level for children as well as for the caregivers, mothers. Over.
Thank you so much. And I think if it's useful, because there are so many questions about specific tools, maybe what we can do is from all the different speakers, we can compile sort of a list of resources and share this. And we can share that in an email after this. I know that Dr. Dalal was talking about some tools from the CDC, and there was a question about developmental screening and disability. And there's a question related to this around, are there early intervention providers who are specifically trained to intervene, to respond to developmental delay in young children in Syria? Dr. Dalal, is there such a cadre of worker? And if so, how are they, how is this working? Just because they're a rare breed in many crisis contexts. Dr. Dalal, we cannot hear you. Are you able to hear us?
Hello?
Yeah, hi. We hear you now.
Can you hear me?
Yeah.
Okay. Sorry, the internet is not stable in Syria. So can you repeat the question? Sorry.
Yes, we wanted to know if there are providers who are specifically trained in early intervention for children who have identified developmental delay.
Yes, we have developed a training program for the health worker in the health facility, depend on CDC, as we have 13 visits for the child from the 0 to 9 months. Each form or application consider all the components of development regards to language, to listening, to movement and body, and also to the mental improvement. So each form, we train the health worker about this issue and how they can provide consultation for the parents.
That's excellent. And were you, for part of the program, did you need to train the providers, or were they already trained through a formal program?
No, we have developed this program and training them. Before we have developed, they didn't train before, no. They have training about IMCI. IMCI is a good program, but not consider all the concept of ECD and how they can provide consultation for the parents.
Okay, thank you so much. So it's, again, good to know that this is that it's possible to train the providers, again, in crisis contexts. And, you know, something that was very moving from your presentation was the comment from the health workers that that they wish they had known this when their children were young. And so I had a question about how the health workers were engaged, because sometimes people will feel like we are coming with an additional thing to do for like in an already stressed environment where there's many competing you know, priorities, and looking at emergency health situations people don't always see early child development as actually an emergency, when we know that it has a massive impact on who comes through the doors of our facility, and what happens to them, how they heal, what their outcomes are, and the risks that they will face going forward. So how easy or difficult was it to convince the health workers to do this kind of work, to do early child development work in the health facilities? Was it a challenge, or was it were they happy to incorporate this into the rest of the health care provision?
It is for me.
Yeah.
Okay. In fact, we try to develop the training program to be very simple and direct for the health worker, and we use a simple language to be suitable for the health worker. When we develop the training program, we design it to be interactive through group discussion, role play, and exercises. And we use very role play in the training to be met the real the life of their life. So all of them feel that this training is met their own life, and most of them said, we hope that this training came before we have grown and our child become. So after they return to the health center, they didn't feel that it's difficulty to implement, because you didn't need specific material, you didn't need a specific space to apply it. Just you have to know what is the message you have to provide it for the parents. So it is just a little bit of change in the style of providing the services, not the new services. And the tool which we have provided to the health center help them to be very simple and systematic.
Thank you. Related to this, I'd like to ask Eduardo and Nasibu, all of you really. There's a question around the health workers that are doing the ECD work in their health, like in these programs that you've described. Are they generalists, or are they child health professionals, or are they specifically, I mean, some of this was from nutrition programs, were they specifically trained in nutrition? Were there any child development experts? Maybe we start with Eduardo.
Nuevamente, buenos días. En el caso de la estrategia PIO, en cada uno de las formas de atención, itinerante o fijas, teníamos un trío o un grupo de 3 profesionales, y en el caso del profesional del área de la salud era auxiliar de enfermería, una persona que tenía experiencia en temas de promoción de lactancia materna, alimentación complementaria, cuidado del recién nacido, y era una persona que en la mayoría de los casos tenía experiencia en respuesta humanitaria, tenía experiencia en contextos de emergencia, había trabajado con otras organizaciones y con otros operadores en ámbitos hospitalarios y en ámbitos comunitarios. Lo interesante del proyecto PIO es que en su mayoría mujeres, al igual tenemos una experiencia maravillosa con un auxiliar de enfermería hombre, porque eso nos permitió darle una perspectiva de género muy valiosa a la intervención cuando se habla de maternar, cuando se habla de acompañar a la lactante, el rol del hombre. Y esta persona en particular diseñó unas metodologías que permitió a los hombres incorporarse de manera natural en el trabajo del amamantar, el trabajo de acompañar a la lactante y de acompañar al recién nacido. Estas personas recibían de parte de nuestra área de salud, nutrición y desarrollo infantil, fortalecimiento de capacidades y cualificación en temas de consejería de lactancia materna y promoción de la alimentación complementaria también. A su vez, estas personas hacían transferencia y fortalecimiento de capacidades a otros actores humanitarios y a otros profesionales, digamos que en este caso, personas del área de la salud que tenían presencia en otros espacios de intervención humanitaria. Gracias.
Thank you, Eduardo. This is also really important to be, I think it's a really important lesson for us, that it doesn't have to be specialists doing specialists in early child development, like in Syria. They can be trained, but also the key is to understand how to adapt to the context, in a humanitarian context. But you brought up another point I wanted to explore a bit further around gender of the health workers, actually. I think there were a couple of presentations sort of discussing, especially focusing on mothers or women, but not necessarily parents or co-parenting. And so, and this obviously has a cultural sort of significance, and it's related also to access to care and who is responsible for accessing care, who comes with the child, which can be heavily culturally or economically determined. So if we could ask maybe Nesibu, if you can tell us a bit about male engagement. Was there any model of male engagement in the program? And if so, how did that work?
Yeah, thank you. So we have also tried to incorporate that piece because it's very important. It's very important. So our model also includes, when we say caregiver, we are not only focusing the mother. We focused on the mother only for the perinatal depression. Even for that one, initially we tried to engage both, but mostly we focus on the perinatal depression, which was at this time went well with the mothers. But on the broader parental coaching or parenting, we were promoting or encouraging both parents, even not only the parents, or it also includes addressing other caregivers or other potential caregivers in the household, including brothers and sisters, and even other caretakers as well. Even in our play session, traditionally in our country, daughters or baby girls play with things which are related to child care or domestic activities, which relate to the gender issue, while the boys play with other separate things like driving a car, flying airplane, or things like that. But just to address at early age this issue, the gender issue, we are promoting the caregivers.
Oh dear, I think we lost Nasibu. But I also think his message was clear. So there's definitely an effort to include both. And I think maybe that's something in the future we can discuss, because it is really important to think about parents and whoever is in the home and has a caregiver role. So with that, thank you so much. This has been really a rich discussion. I would like to hand back to Maria to close up and tell us a little bit about our next webinar to come. Thank you so much.
Thank you so much, Aisha, and to our wonderful speakers for today, for sharing such incredible experiences that we can all learn from. And to everyone who joined us today, thank you for taking the time to learn more about programming in action and how to incorporate nurturing care into national responses, national health responses and systems. Please remember that this is part of a webinar series. We still have our third webinar to go. This will be held on November 9th. And with the recording and the slides, you will be receiving over email the link to register to this third webinar. Thank you so much again for your engagement, and we'll look forward to seeing you in our third webinar.
Thank you, Maria. Thank you, everyone.